So the first bullet, we'd like you to just keep holding this question throughout the day, this notion of continuing to build on collectively your sense of what are the insights that are most important, and we'll work toward that at the end. But for the second bullet, are there any questions or insights you'd like to hear more from the panel on? We won't have time to hear from everyone, but if a table has a question for Maria and Linda, could you raise your hand? And Randy will run over.
Hi, Diane Feingood, SFU. So it struck me in the list of places that NIH is investing their money that it stopped at clinical trials when you talked about the fact that we have evidence that we're not putting into action, and there's no knowledge translation research listed there. There was no implementation science. So where are we getting that work, that critical work done?
Oh, also, could I ask you to introduce yourself as you speak? Sorry, I meant to say that.
I did, but Diane Feingood from Simon Fraser University.
Thank you.
So I think that's a really important question. The list that we have up here is the list of approved spending for the money that we got, the $500 million. And so it's actually expanded a little bit in the last couple of weeks, but I'm not supposed to release things first. HHS is supposed to do that. But we are moving forward with a set of, it has an acronym for it, but a set of pragmatic trials that will help us move some of these, some of the research that we know where there's evidence base into healthcare systems, into the VA, into the DoD healthcare system, and also into the larger private healthcare systems. So that's a huge need, and I think SAMHSA is also part of that, and so it's very much on our minds. This was a little bit of an early. We have almost no infrastructure for pain research. So moving, we're kind of moving from the ground up, and so this is sort of our foundation from the diagram that I showed.
That's great. Thank you. Yeah.
Janet Pope, I'm a rheumatologist at Western in London. So our group had a couple of comments. So one was basically determining things before they're a crisis, so the pre-intervention, the at-risk, what happens in the emergency room and things. But the other thing we think might be outstanding is your heat map of the overdoses in the US is probably directly related to the variation in prescribing patterns. And we think without punishing the patient, if we could re-educate the key opinion leaders in the practice groups, hitting the high risk because they're the high risk or the high prescribers, to kind of re-educate them that there's other alternatives and that we might be doing more harm than good. I think that might actually, for the next generation of patients, make a huge difference, and I think we need research in that area.
Yeah, so I'm going to back up a little bit from that, but one of the good things, which is, it's not overall positive, but that a lot of the overdose deaths now are due are in people who did not start with prescription opioids. They started directly with illicit drugs. So our prescribing rates have gone down quite a bit. Unfortunately, the overdose rates have not. And so, we're fighting a totally uphill battle. But prescription practices are being looked at really carefully. There's been a lot of money that's gone into monitoring prescribing, monitoring level of prescribing, overseeing and contacting physicians that they think are overprescribing, and also built into that training programs and resources for prescribers, and also for providers, whether they're prescribers or not, of pain care. And we're pretty far behind in the education on pain care piece. The prescribing education, I think, has been pushed really hard. So hopefully that gets up most of your question.
So Maria?
Yeah, I just wanted to comment on that because I think what we have seen is a huge focus on prescribing as a driver of the problem. And I think the evidence really tells us that that is a small piece of the puzzle. So if you look at those heat maps and you overlay a map of social and economic disparities in the US, that will tell you a different story. So I think we need to understand pain in a social context. We need to understand it in a political context. We talk about opioid prescribing. In the US, you don't see huge rates of overdose and use of opioids in the African American population because people's pain is not being treated in those communities, because the institutionalized racism is also driving who gets access to opioids. So there's a huge number of complex issues, and I think, Linda, I've heard you speak a number of times when you have a bit longer and kind of talking about that broader context, and I think in Canada, we need to be paying attention to that. We've been so appreciative of the work in the US focusing on disparities because, quite frankly, in Canada, in the pain discourse, a focus on disparities has not taken center stage. So we do not yet see the issues of Indigenous communities, the issues of refugees and newcomers, and kind of the overlay of social issues and disparities on our discussion about pain in Canada. And we really need to go there. That's something our organization is increasingly focused on. So I want to appreciate the work that you've done to bring the issues of equity and disparities into the national strategy and pose that as part of our additional challenge here.
So I'm going to ask, just in interest of time, if you can hold that, we're going to go to the third question, which I think Karen has.
Yep,
yeah.
thanks.
A new fellow.
Is this on?
Yeah.
Thank you. Karen Davis from Toronto and President-elect of Canadian Pain Society. So what I was going to say actually picks up on what Maria was just saying. There's a lot of great work that many people in this room are doing and plan to do in different silos. But to actually make something happen in terms of a plan requires tremendous savvy in terms of politics, moving forward with policy, and also to change the conversation in terms of stigmatization, as you both mentioned. Make this like cancer. It's not a blame game. So how do we do that? How do we to move forward? How do we get the politicians to recognize this, whether it's through personal stories or we could throw data at them all we want, but to change the conversation, remove the stigma, and to put it in a positive context that this is something that we can fix. This is something that we can do something about. And, so I think both of you have moved forward tremendously. And what can we do for a national Canadian strategy based on your experience?
So can we start with Maria and then? Yeah.
Sure. Thanks for that question, Karen. We have really used so many strategies to move the agenda forward. Everything from, in our provincial system, we need to work the political angle. So that means meeting with MLAs, meeting with ministers. We need to work the bureaucratic angle. So that is having deep relationships with bureaucrats that are in the system. We need to mobilize people who live with pain because they vote their constituents for politicians. We need to give them tools to talk to people in their community, talk to their local newspaper. It's all of those strategies that we've moved forward. And in our case, we started when we didn't have a provincial strategy. We were a tiny little organization, no money, no staff, nothing. And it really was about finding people who were impacted by our issue, who cared about our issue, aligning their cause with ours and helping them to see whether you're the College of Pharmacists, the Medical Association, a local GP, a local hospice association, whoever they were, what is their stake in our issue and what's the ownership that they should have over the issue of pain. And then presenting a very compelling case. I remember being at our Ministry of Health a few years back, and we had done an analysis of all of the ministry's strategic priorities. And we sat in that room and we said to them, every single one of these, we had the data to back it up, this is how pain is impacting everything you're trying to do and you're not seeing it. And those kinds of things really make a difference. Certainly the opioid crisis, we've had to be shamelessly opportunistic in trying to exploit something that is terrible and a crisis to advance our agenda, not just for people who live with pain, but also for people who live with pain and substance use. So there's many, many strategies, and my own belief is you need to use all of them and be strategic in choosing when and how, but sometimes you're going to bang your head against the wall. You need to go through the back door.
So I think our perspective is a little different because we have certain restrictions of what we can do and who we can talk to. But one of the things I think is work with the patients and the patient advocacy groups. So they come to basically all of our meetings, all of our workshops, they're on all of our working groups. And so hearing what their needs are and also helping to educate them about what policies are being considered, what's being put into place, what needs to be moved forward. So we can't ask them to go to their congressman, but it's clear that if they're well informed when they go, that it's incredibly helpful, that they know what we're doing, they know what our intentions are, and we can educate one another. I think also from sitting in the perspective of my office, the pain policy office at NIH, that I have the ear, or our office has the ear of a lot of different level appointees. They're not politicians because I can't go to my congressman and talk to them about what I do at work and try to promote it. But we can talk at people in the assistant secretary's office, the secretary's office, and tell them, about the importance of making sure that every single document that goes out the door on managing the opioid crisis has something about pain care, pain management in it. And we've been really forceful in trying to make sure that messaging goes out. So we're a little bit more restricted in what we can do, but we do have the ear of people who can actually make a change. It's been a little challenging these past year or so because we'll brief the secretary's office and then there's a new secretary and then there's another one. So anyway, those are, the challenges are there, but the education and talking to the patients is important. FDA had a meeting 2 or 3 weeks ago to invite public comment only. So it wasn't an advisory committee, it was a public comment day where people with chronic pain came in and told their stories. And it was just incredibly, incredibly moving because people now are just not getting what they need. And so I think just having that public comment session that was videotaped and available, that kind of thing can make a big difference with the politicians.
So I think that's our time for this panel, but thank you both so much for bringing the full dimensions to this and keeping the patient at the center, which I think is really an important part of the conversation today. We do have a patient, somebody with lived experience as part of the panels this afternoon, so you'll have a chance to have that perspective as well. So please join me in thanking Linda and Maria.